Last week, a man walked into my office. He looked exhausted, eyes sunken, hands trembling just a little. He was 52, healthy looking, strong voice, but he hadn't slept in days. He leaned in and said, "Doctor, I just found out I have plaque in my carotid artery. I can't stop thinking about it. Is this a death sentence? Am I walking around with a ticking time bomb in my neck?" He wasn't alone in that fear. Every week I meet patients who come in holding a piece of paper, a scan result, a percentage. Maybe it says 40%, maybe 70, sometimes more. And along with that number comes something heavier, fear. Fear of stroke, fear of surgery, fear of what's coming next. Now here's the part most people don't know. Not every blockage means you're in danger. Not every scan result means you need surgery. And no, being told you have plaque doesn't always mean you'll have a stroke. But I get it. The word plaque sounds threatening. The word stroke sounds terrifying. And when those two show up together in a conversation with your doctor, your mind starts racing. That's why today I want to walk you through this. Gently, clearly. I want to show you what carotid artery disease actually is, when you need to worry, and when you don't. Because the truth is, sometimes the best treatment isn't surgery. Sometimes it's peace of mind. Let's start simple. You have two carotid arteries, one on each side of your neck. These are the main highways carrying oxygen-rich blood from your heart to your brain. If those arteries get blocked, your brain doesn't get the fuel it needs. And when the brain doesn't get oxygen, even for just a few minutes, cells begin to die. That's what we call a stroke. Now think about this. Your brain controls everything. Your ability to speak, walk, smile, remember, even breathe. A stroke can rob you of any one of those things in the blink of an eye. That's why carotid artery disease matters. Because it's not just about blood flow, it's about independence. It's about quality of life. But what causes those blockages? Over time, fatty deposits, what we call plaque, build up inside the artery walls. This plaque is made of cholesterol, calcium, fibrous tissue, even small clots. Sometimes it builds up slowly, narrowing the artery like rust in an old pipe. Other times, a piece of it breaks off and travels to the brain, blocking smaller vessels. Both can trigger a stroke. Here's the thing. Most people don't feel any symptoms. Carotid artery disease is quiet. You don't get a warning light on your dashboard. You may not even feel different until something serious happens. And that's what makes it dangerous. Not because it always leads to disaster, but because you might never know it's there. That's also why early detection matters. When we find it early, we can often treat it without surgery. We can prevent the stroke before it ever happens. And that is the power of understanding, not just what these arteries are, but what they do. So instead of living in fear of the unknown, you get to live with knowledge. And knowledge brings options. Now that we understand what the carotid arteries do, let's talk about the question most people have right after they get their scan results. How bad is it? The answer depends on two things: how blocked your artery is and whether you've had any symptoms. Let's start with the numbers. When a carotid artery scan shows less than 50% blockage, that usually means the blood flow is still strong. The risk of stroke at this stage is very low. In most cases, there's no need for surgery. Instead, we focus on lifestyle changes and medications that help slow or even stabilize the disease. Between 50 and 69% blockage, we start watching more closely. If you're not having symptoms, we still often treat this with medicine and monitoring. But if you've had a warning sign, like a mini stroke, also called a TIA, this range may need more serious attention. Now, when a scan shows 70 to 99% blockage, especially if you've had symptoms, that's when surgery becomes a more likely option. At this level, the risk of stroke goes up, and we want to act before damage occurs. But even here, we don't jump to conclusions. We still consider your age, your overall health, and what kind of plaque we're dealing with. And finally, there's 100% blockage. This means the artery is completely closed off. Ironically, in many cases, we don't operate at this point. Why? Because if the brain has already found new pathways, collateral circulation, to get blood, surgery may not help and could even pose risks. Here's where it gets confusing for patients. Two people can have the same percentage of blockage, but only one may need surgery. Why? Because symptoms change everything. If you've had a stroke, a TIA, or other neurological signs, even a 60% blockage might need intervention. But if you're symptom-free with 80%, you might be fine with medication and close follow-up. And that's why context matters. A scan gives us numbers, but your story, your symptoms, your health, that gives us the full picture. So instead of asking, is 70% bad? The better question is, what does this mean for me? Because the goal isn't just to know the number. It's to know what it tells us and what we can do next to protect your brain. It's one of the biggest questions my patients ask. Do I really need surgery? And the truth is, not always. Let's walk through it together. There are two main procedures we use when surgery is needed for carotid artery disease: carotid endarterectomy, CEA, and carotid artery stenting, CAS. Each one has a place, and knowing when to use, which is part of the art and the science of vascular care. Carotid endarterectomy has been around for over 50 years. It's the gold standard. During the procedure, we make an incision in the neck, open the artery, and gently remove the plaque by hand. It takes about an hour, and most patients go home the very next day. Stenting, on the other hand, is less invasive. Instead of opening the neck, we go through a small puncture in the groin. We insert a catheter, guide it up to the carotid artery, open the blockage with a balloon, and place a stent, a tiny mesh scaffold, to keep the artery open. This is often reserved for people who are too high risk for surgery. So how do we decide? A major study called the CREST trial compared both methods. For many patients, the results were similar, but for people over 70, CEA tended to be safer. For younger patients or those with complex health issues, stenting might be a better fit. It's not one size fits all. But here's the key. We don't recommend surgery just because there's a blockage. Surgery carries risks, just like any procedure. The goal isn't to clean the pipes, but to reduce your risk of stroke. That's why we only consider it when the benefits clearly outweigh the risks. Let me give you an example. If you have 80% blockage but no symptoms and your plaque is stable, we might watch it. But if you've had a mini stroke or a stroke, even with 60% blockage, that changes the picture. Your risk of having another event goes up, and that's when surgery can be life-saving. There's also the NASIT study, which showed that patients with 70–99% blockage and symptoms benefited most from surgery. But for people under 50% blockage, even with symptoms, the benefits weren't clear. Bottom line, we don't operate based on numbers alone. We operate to prevent stroke. If that risk is high and the procedure can lower it safely, that's when we act. So instead of asking, shouldn't we just remove the plaque now before it causes trouble? Consider this. Instead of risking a procedure you might not need, what if we monitor closely and act only when the risk becomes real? Because doing nothing isn't the same as ignoring the problem. Sometimes doing less is doing what's best. Here's something many patients are surprised to hear from a surgeon. Sometimes the best thing we can do is not operate. If your carotid artery disease is mild or even moderate, and you haven't had any symptoms like a stroke or TIA, you might not need surgery at all. In fact, with the right treatment plan, you can lower your risk of stroke significantly without ever stepping into an operating room. So what does that plan look like? First, we focus on stabilizing the plaque. The goal isn't to melt it away like some magic soap commercial. That's not how the body works. But we can make the plaque less likely to rupture or grow. That's where statins come in. You've probably heard about statins as cholesterol-lowering drugs. And yes, they do that. But that's not the only reason we use them. Statins have a unique ability to reduce inflammation inside the arteries and stabilize plaque. Multiple studies, including a large meta-analysis, show that statins can lower the risk of stroke by up to 25%, even in people who've never had one. Then there's aspirin, a tried-and-true medication that helps prevent clots from forming. It's like reducing the stickiness of your blood. So if a piece of plaque does break loose, it's less likely to trigger a clot that could block a brain artery. Blood pressure control is another major pillar. High blood pressure puts extra stress on artery walls, making plaque more likely to rupture. By keeping your numbers in a healthy range, we reduce that risk dramatically. And finally, there's lifestyle. No one loves hearing this part, but it matters. Quitting smoking, getting regular movement, eating foods that protect your heart, not attack it, losing even a small amount of weight. These choices aren't about perfection. They're about giving your body every chance to heal and protect itself. And here's the beauty of medical management. It works. I have patients I've followed for 10, even 20 years who never needed surgery because they stayed on their meds, stayed on track, and their arteries stayed stable. So instead of jumping into a procedure you may never need, we monitor. We check in regularly. We repeat scans. We catch changes early. It's not doing nothing. It's doing what's right for you based on your risk. Because sometimes the best stroke you'll ever have is the one we prevent from ever happening. Let's talk about something that doesn't get enough attention. Where you get your carotid ultrasound matters a lot. Every week I see patients who come in with results from a screening they got at a community center, a pharmacy clinic, or even a mobile van parked outside a grocery store. The printout says something like 80% blockage, see a doctor immediately. Naturally, they're scared. But after we perform a high-quality scan in our accredited vascular lab, we often find something very different, sometimes 50%, sometimes even less. That's not just a small difference. That's the kind of difference that determines whether you need surgery or just a follow-up visit next year. Why does this happen? Because not all ultrasounds are created equal. A carotid duplex scan isn't just a picture. It requires a trained technologist, the right equipment, and most importantly, interpretation by experts who understand what they're looking at. In an accredited vascular lab, we meet strict national standards. The machines are calibrated, the people doing the scan are certified, and the results are reviewed with care. In an unaccredited setting, that level of precision may not be there. Imagine if someone measured your blood pressure with a broken cuff, then based your entire treatment plan on it. That's what it's like relying on a low-quality carotid scan. And I get it. People want answers quickly, but in this case, a fast answer can lead to unnecessary fear, or worse, unnecessary procedures. So if you've had a scan done somewhere else and the numbers seem alarming, don't panic. Get a second scan. Get it done right. Because the first step in choosing the right treatment is having the right information. If you do end up needing surgery, here's the good news. Recovery is usually quick, and life can get back to normal faster than you might think. Most patients who undergo carotid endarterectomy are up and walking the next day. The incision might feel a little sore in the neck, so we usually recommend waiting a week or so before driving. If you've had a stent placed through the groin, the recovery is just as fast, though you might feel a bit of tenderness where the catheter went in. But surgery is just one chapter. What comes next is just as important. We typically schedule a follow-up appointment a few weeks after the procedure. We check your incision, make sure everything's healing properly, and, most importantly, we start planning your long-term protection. You'll have regular carotid ultrasounds, usually once a year. to make sure the artery stays open and that new blockages aren't developing on the other side. Remember, this disease tends to affect both arteries over time. And here's something many patients don't expect. Even after a successful surgery, we continue medical therapy. That means staying on your statin, taking your aspirin, managing blood pressure, because while the surgery fixed the current blockage, it didn't erase the underlying condition that caused it. It's not about fear, it's about staying in control. Instead of thinking, whew, that's over, I encourage patients to think, now I've got a second chance. How do I keep it? And when you follow through, when you show up for those checkups, take the meds, stay active, your chance of avoiding another stroke or a second surgery goes way down. So the goal after surgery isn't just healing, it's thriving, it's staying ahead of the disease, and it's knowing you're doing everything you can to protect your brain and your future. At Johns Hopkins, we have the latest technology, cutting-edge research, and decades of experience treating vascular disease. But if you ask me what I'm most proud of, it's not the surgeries or the data, it's how we care. Because behind every scan, behind every artery, there's a person, a mother, a grandfather, a neighbor who just wants to make it to their grandson's graduation, or dance at their daughter's wedding, or simply walk to the mailbox without worry. That's why our team sees its mission clearly, not just to treat plaque, but to care for people. We take time to explain. We listen to the fears. We help our patients understand what's happening and what's not. And sometimes that means saying, you don't need surgery. You're going to be just fine. That kind of reassurance doesn't show up in the statistics, but it changes lives. Because when you leave our office, we don't want you walking out more confused than when you came in. We want you walking out with confidence, with clarity, and with a plan, and above all, with peace of mind. If you've recently been told you have carotid artery disease, take a deep breath. This isn't the end of the story. It's the beginning of a smarter one. Before rushing into decisions, talk to a vascular team that has all the tools, not just a hammer looking for a nail. Get a second scan, ask questions. Make sure the plan fits you, not just your numbers. Because sometimes the right treatment is surgery, but other times the best thing we can do is help you worry less. And that kind of care, you deserve nothing less.